Thank you for this opportunity. Okay. So this is a 59-year-old male patient presenting with a characteristic PCV fundus appearance and featuring orange-red nodules and the subretinal hemorrhage on OCT scan. And OCT scan shows a PED and subretinal fluid and the ring-shaped lesion, and underneath the elevated RPE. And likewise, ICGA images demonstrate cluster of polyps, and a finding also confirmed by the OCT angiography. And regarding this clustered lesion and what could be initial approach as a treatment. So we started with a 3-monthly loading of aflibercept, and while the subretinal hemorrhage resolved and there was a persistent subretinal fluid and sustained clustered polypoidal lesions even after the loading dose of anti-VEGF monotherapy. So we continue the treatment with bi-monthly aflibercept monotherapy, but we could not achieve a dry macula even with 2 additional injections at the month 6. And we continue with bi-monthly injection. And as you can see in the bottom, finally, at the 1-year follow-up, these RPE protrusion and subretinal fluid disappeared. And year 1 ICGA image demonstrate the complete closure of the polypoidal lesion. And up to at year 3, and there was no recurrence of exudation or the polypoidal lesion without any further treatment. So you hear about the polyp closure rate after in a clinical study. So anti-VEGF monotherapy achieved a complete regression in about 30 to 40% of patients in clinical trials, and in up to 55% in individual studies. Moving on to the next case, this is a 63-year-old male patient who had the history of intravitreal bevacizumab and ranibizumab, after which he could discontinue the follow-up for several months. And when this patient presented, there was no evidence of exudation on OCT scans. And there is a large branching vascular network and the multiple polypoidal lesions at margin on OCTA images. And due to the appearance of dry macula and this continuation of treatment for several months, we decide on the close monitoring with 3 months interval. And 4 years later, we observed a subretinal hemorrhage and a peaked PED during a follow-up examination, and patient did not report any vision changes at this point. And comparing to the original ICGA, a new large polypoidal lesion related to subretinal hemorrhage developed. And there was also a spontaneous regression of 1 polypoidal lesion near the disc. So although there's no fluid under the fovea, and we started with the 3-monthly ranibizumab as a retreatment, and a new hemorrhage appeared, and then we continue with 3 more monthly injections of ranibizumab. And however, another extrafoveal hemorrhage appeared, and then we switched to aflibercept at month 6. And still, the lesion remained unstable, and a new subretinal hemorrhage just below the disc appeared. And although we switched to the brolucizumab, another large disc hemorrhage developed, and we had to continue with the bi-monthly brolucizumab. And eventually, the eye stabilized with the brolucizumab TNE regimen, and we are considering discontinuing treatment. So recent study from Korea demonstrate that the increase the height of RPE protrusion on the sequential observation was a significant risk for the exudation conversion in the PCV case. And they also reported a hypertension as it could be a risk for exudation. And in our PCV analysis, hypertension appeared significantly related to the persistent polypoidal lesion. So getting back to the case, a serial follow-up OCT scans before the subretinal hemorrhage, an increase of PED height, and the change in internal reflectivity are well shown in this case. And we may need to look at through the all OCT scans in this kind of case. In the real-world data, PCV has been reported as significant factors for discontinuation of treatment and retreatment of neovascular AMD. Thank you for your kind attention.
Thank you. So now we have time for discussion.